Okay, welcome everybody, and I'd like to thank organizers for inviting me. Now I'm going to try to say no. First, I have to admit that levodopa in the treatment of Parkinson's disease is the drug with most favorable symptomatic control, as Professor Stucci eloquently said before me, and is almost always associated with better quality of life. And side effects like dyskinesia is frequently preferred by patients to poor symptomatic control, and generally accepted to be free of awkward side effects like impulse control disorders. So why would ever someone want to use any other drug than levodopa? You may want to use dopamine agonists to facilitate the national economy through an increase in the income of casinos and shopping malls. Or you may challenge the cognitive capacity of the patients by complicated dosing regimens of dopamine agonists. This will lead you to diagnose Parkinson's disease dementia at the early stages. And it is PDD-MCI is an important factor as discussed yesterday. Or is there any other rationale behind using any other drug other than levodopa? There are 3 studies mentioned here. These are very good studies. They have 2 arms. In one treatment, it started with a dopamine agonist, and the patients in the second arm were treated with levodopa from the start. What is fascinating about these studies is twofold. The one property is that patients started with agonists from the start are allowed to use levodopa whenever symptoms were not satisfactorily controlled. And the second part is, for all these 3 studies, the incidence of both dyskinesias and wearing off are declared. And as you can see, both the incidence of dyskinesias and motor fluctuations are less frequent in the patients who started with dopamine agonist and added levodopa whenever it is symptomatically needed, when dopamine agonists are not enough for optimum symptomatic control. And as a result, it's fairly reliably proven that if you start with an agonist and add levodopa whenever it is needed, when the patient's symptoms are not controlled satisfactorily, dyskinesias and wearing off are less frequent. But then are dyskinesias and wearing off clinically important so that we should try to avoid them? Somebody asked the patients, would you prefer Parkinsonism or dyskinesias? And most of the patients, 80% of the patients, told that I would prefer peak dose dyskinesia rather than being Parkinsonian. That's okay. But this study is performed mostly in a Western population. If we ask the same question to Japanese patients, you see only 25% of the patients from Japan prefers dyskinesia over Parkinsonism. There is a vast transcultural difference. If you treat a Western population, which constitutes less than 1% of the world's population, dyskinesias may not be important. But if you treat someone from Japan, he or she would rather be Parkinsonian rather than dyskinetic. One may argue that troublesome or disabling dyskinesias has no difference between the groups who started with agonist first or levodopa first, as it is shown in Calm PD study. But the things are different in ropinerol study. In the ropinerol study, disabling dyskinesias are much more frequent in patients treated with levodopa from the start. Normal dyskinesias are, as you all know, already with higher percentage. So when measuring the effect of a treatment intervention, what we care about should not be pathology, handicap, disability, activities of daily living. It should be quality of life, because this reflects what patient feels and lives better than all the other parameters. I could find only one study which investigated the effect of quality life of dyskinesias and motor fluctuations. And the most important factors associated with worse quality life is number of levodopa doses, motor features as measured by UPDRS Part 3, and dyskinesias. So dyskinesias are among the most important factors that affects quality of life worse. And as you can see here, most of the items of the PDQ 36, the quality of life rating scale, and the summary index total score is better in patients without dyskinesia when compared with patients with dyskinesia. So dyskinesia has a negative effect on quality of life. So it's probably, we can be sure that dyskinesias are important, and especially troublesome dyskinesias are really troublesome. So is wearing off or end of dose deterioration clinically important so that we should try to avoid it? What does wearing off mean? One definition is that clinical effect of levodopa lasting less than 4 hours. Wearing off is frequent. You can detect wearing off more than 50% of patients with Parkinsonism duration 2 years. And it is the greatest challenge, according to 63% of primary care physicians and according to 55% of patients. And wearing off is also strongly associated with worse quality of life. So, let's try again. Could anybody help me to? It's not actually so important. Let's try here. Okay, what I expected you you to see is the same patient with yeah.
Ali Saraç, Peksola 3x3.
Turn off the sound, please. Yeah, this is a patient with troublesome dyskinesia. And could you please turn on the second video? You know, none of us would say this non-disabling. The next video, please. And the same date, same patient when he's off. So if we turn off the videos, please. If we want our patients to be free of troublesome dyskinesias or wearing off, starting with a dopamine agonist from the start and add levodopa whenever it is needed seems to be a good treatment option. Now let's switch to a totally different group of Parkinsonian medication, MAO-B inhibitors. There are 3 properties of MAO-B inhibitors which makes them a very useful drug groups for the treatment of Parkinson's disease. The first good property of this drug group is they mostly use once daily, and they don't need any titration, like levodopa and dopamine agonist. Unlike levodopa and dopamine agonists, they don't need titration, and they only use once daily. In this graphic, you are seeing what our dear patients do. At this point, we told them take this drug like this at these times of days, and at the end of 1 year, only 20% of them does what we want them to do. And only drug that is statistically significant in terms of adherence is rasagiline, and this may be because it's used only once daily. If a drug is used once daily, the patients are more adherent. Patient compliance is much better. And as you will remember from the previous slides, a number of levodopa doses was associated with worse quality of life. So as an extraction, decreased number of a drug should maybe associated with a better quality of life. So as a result, this may mean better adherence and better quality of life. The second important quality of MAO-B inhibitors is their perfect or close to perfect safety profile. When randomized controlled trials with rasagiline analyzed, namely Tempo, Presto, Largo, ADAGIO, nausea is more frequent than placebo only in Presto study, and dyskinesia is more frequent only in LARGO study. For all the rest, no side effects, systemic or dopaminergic, is more frequent than placebo. And this is performed, these are studies performed more than 2,000 patients. And the third property is the probability of MAO-B inhibitors having disease modification effect. There are many studies performed both with selegiline and rasagiline to investigate whether they have neuroprotective or disease-modifying effects or not. This example is taken from Tempo study. At this point, patients with equal amounts of Parkinsonism with similar period of disease are put on rasagiline either 1 or 2 milligram. Down is better, up is worse. You know, they, you see, get better and slowly goes up. And the placebo group, as expected, they done worse. And at the end of 6 months, when patients on placebo group were put on rasagiline, they are not as good as patients who were on rasagiline from the start. So this may be an evidence that rasagiline has disease-modifying properties. This has been shown several times with different methodologies, and the only exception among good methodology trials is a 2 milligram day arm of ADAGIO trial. These patients are not different from the patients who are on Stalevo in terms of disease-modifying effect. All the other studies show that rasagiline or selegiline may have a disease-modifying effect, may slow down the progression rate of the Parkinson's disease. So let's come back to the question again. Why would ever someone want to use any other drug? You may want to use MAO-B inhibitors because they are effective, easy to use, they have perfect side effect profile, and there is a probability that they may slow down the progression rate of Parkinson's disease. And you would want to use dopamine agonists because they decrease the frequency of dyskinesias and wearing off. They are frequent and disabling. And don't forget that you should add levodopa whenever symptoms are insufficiently controlled by these drugs. So my last slide. Optimal strategy of the treatment of Parkinson's disease should be like this. In the early stage patient, you may start with a MAO-B inhibitor because it's easy to use, once a day, no titration required, etc., as I told before. But you should keep in mind that never leave the patient in bad symptomatic control. You start with, let's say, rasagiline. After 3 weeks, even after 2 days, you should wait for at least 3 weeks to get the best out of the rasagiline. But this is something specific to this drug. If you feel that patient's symptoms are not controlled sufficiently, you should switch to dopamine agonists. Why? Because with this treatment, you see less frequent wearing of dyskinesia, and these are important clinical features affecting the quality of life of the patients inverse. But as soon as you have seen insufficient symptomatic control or troublesome side effects, you should add or switch to levodopa because it's the drug associated with best symptomatic control and always with better quality of life. As far as I understand from what I read about the treatment of Parkinson's disease, and plus my experiences, in the early stage of the treatment, I would start with a MAO-B inhibitor, I would switch to a dopamine agonist, and then if these drugs are not enough, I would switch or add levodopa to the treatment. The critical point is that you should see the patient frequently, as frequent as 6 months, once in 6 months, and you should monitor the symptomatic efficiency of the drugs. Okay, that's all I want to say.